Thank you. Thank you, Doug. Before I get started, I wanted to say something about stigma, and I have an anecdote that is true. When I talk to house officers and residents, they always ask me, as a medical oncologist, how is it that you can take care of lung cancer patients? This is something that usually happens, and interns will ask, and there's this idea that, because of the risk, because they've done this to themselves. And so what I say is, and please, if anybody skis, don't take this personal, but I always say, well, if somebody breaks their leg skiing, you don't say to them, why'd you go down a hill 80 miles an hour and wax plastic? You don't do that. You fix what you can and you prevent the things from happening going forward. And I think that that's an important thing when you talk about stigma. And we're going to get into some of the qualitative work that we've done in talking to patients who might be at risk for lung cancer, and actually to lung cancer patients as well. So what I want to do in this talk is really talk a little bit more and focus on socioeconomic status and racial disparities in lung cancer, which is an area where I've been for almost all of my career. Talk a little bit about the NLST and vulnerable patient populations, some of the subgroup analysis that have been done, and then focused at the end, perceptions of lung cancer by race. And there's some published work that we discuss, and actually talk a little bit about that and smoking cessation. And then at the end, finish up with some reflections and implications for screening, and time permitting, talk a little bit about our experiences in a federally qualified health center where we've tried to implement some of these and the challenges that's come up in that. So also just want to give you my disclosures, right, in fairness. Right. All right, so this room is a friendly room, so I don't have to remind all of you that unequal treatment, when it came out in 2002, was really important to discuss and frame the idea of health disparities across the spectrum. So you can list any health outcome that you would like to, and those who are poor, those who speak a different language, and specifically African Americans, seem to have poorer outcomes. And I think, again, here it's a friendly room, but I can tell you that when you're going into communities and you talk about this, people sometimes are still surprised. Our epidemiologists, our public health friends also all know this very well. I think for treating clinicians, it's very difficult sometimes for them to really conceptualize this and realize this. I think that this framework, as illustrated in Quagga Singer's in her paper in 2010, is really useful, and I go back to it over and over again. Really looking at the difference is a good way to describe disparities, the difference between non-minority populations and minority populations. Difference is okay, right? There's nothing wrong with difference. Difference can be split into clinical appropriateness and need preferences. That's okay. But the bottom two, operation of the healthcare system's legal aid, regulatory climate, and discrimination and biases, that's the disparities part. And you really can break disparities out into biology, epidemiology, socioeconomic status, race and racism, and culture and ethnicity. This paper in particular does a really good job talking about culture as opposed to just ethnicity. I think we spend a lot of time on race. We spend less time on socioeconomic status, which we really should be spending more on that. But we also spend very little time on culture, which really goes across race and socioeconomic status and has dramatic impact. So today, I can't talk about that today, but if you get a chance to go back and look at this review, she does a really good job of talking about that. This is to remind me to talk a little bit about the pervasive impact of the tobacco industry. So when I go into schools and I talk about lung cancer and I talk specifically about tobacco cessation, I always show this slide, and I actually ask these sometimes middle schoolers or high schoolers if they know who this is, and I can tell you half of them still do, which is amazing since they shouldn't have been able to see him for almost 10 years now, right? It was 2007 when R.J. Reynolds said that they would stop utilizing Joe Camel. And I just, again, as a clinician who treats lung cancer patients, we cannot forget the targeting that happens first, starting in high school and middle school and going forward, and what we're seeing with e-cigarettes going on now. All right, coming back to incidence and death rates for lung cancer. So again, I'm sure you've seen this now in many different ways. But if you look at the incidence rates for lung cancer, specifically comparing non-Hispanic whites to blacks, you can see that the incidence rates are higher for blacks. And actually, one of the things that's interesting about this is we don't talk about the gender breakdown. Almost all of this is really in African-American men. If you really look at the slides and you really go back and look at the data, the differences for African-American women and white women is negligible. Actually, in some studies, the survival sometimes a little bit better. All of this is driven by men. And then when you look at mortality, again, you can see that as well. And for a cancer that's so stage-driven, which I'll get into in a minute, more so than some other solid tumor cancers, it's so stage-driven. I think that, to see a disparity here, it's not just about tobacco and tobacco exposure. So summarizing a lot of this, the incidence rates and mortality rates of lung cancer are highest in African American and Black men. And over the past 40 years, we've had this decrease in lung cancer incidence. You've seen that slide from before. The gap is narrowing, but it seems to not be narrowing the way we want it to and at the speed we would like it to. And actually, if you take that same slide, which I'm not showing you now, but where they show you the gaps, African Americans on top with the higher mortality rate and whites below, if you go back to 1970, those lines were on top of each other. So you go back and take a look at the SEER data and you look at the survival differences for lung cancer in 1970, and you can argue, well, that's probably because our treatments weren't very good. But that does suggest that perhaps access could really be contributing to some of the disparity, and it's not just a biologic or issue. This is also just to talk about tobacco. For those of you who follow this issue of tobacco in different ethnic groups, there's a lot of data that's all over the place about this. But basically what we can see from reviewing the data is that we know that African Americans smoke different cigarettes. We know that they smoke differently, but there hasn't been a link specifically, at least convincingly in the data, that says that is the reason for the disparities. And actually, if you remember that Harriman paper, which was I believe back in 2008 or so, where they actually, in New England Journal, where they suggested that there could be some differences in how tobacco is metabolized. And again, we haven't had any follow-up data from that, but there's something that's happening that's not just smoking. So there was work done by many in this room, including Peter, he's still here somewhere, where we really know, I would summarize this way. You pick a modality for lung cancer, whether it's surgical, whether it's radiation oncology, whether it's giving chemotherapy, whether it's targeted therapy for lung cancer, African Americans are less likely to get it. I mean, we've been proving it over and over and over again for the last 20 years, and we haven't seen any differences in that. And the other thing we've seen when we've published some of these papers, if you look at the subgroup analysis for folks who get surgery, because let's be very frank, surgery is the only thing that is curative in lung cancer. That is the only way you're going to cure lung cancer. Our treatments have gotten much better. We've seen a lot. Our approaches have become more nuanced, and progression-free survival has improved, but surgery is the only way still to cure lung cancer. And when you look at these studies and you look at who obtained surgery, these disparities usually narrow and go down to zero. Basically saying if you get surgery and you're African American, your outcomes are very similar to that as whites. Even though you have more comorbid disease to begin with, even though you present with later stage disease on average, if you get equal treatment, you get equal outcomes. And I think that's also really important when you add on to screening. You can see where we're going with this. And this is an editorial comment, but what are the improvements in lung cancer treatment have on disparities? As I mentioned, I think if you get people to surgery, because surgery is curative, that probably will help you with the disparities. And we published some of that in early on in some of our work in SEER Medicare. So let's talk about income, because again, I told you we talk about race too much, and then what am I doing? I'm talking about race a lot. So I just want to make sure we talk about lung cancer and income. Income in SES or socioeconomic position, depending on how you like to think about this, has a special importance in lung cancer. It's dramatic throughout, and we'll show you some of the Walker studies that actually talk about this throughout other cancers. But lung cancer has this double jeopardy phenomenon. So if you are poor, you have an increased risk of being exposed to tobacco from your own personal use, and et cetera. You also probably, we're not going to talk about particulate matter and where you live in urban areas, but there's probably some issue there too. And we also know being poor increases your risk from dying from lung cancer. Income is directly related to stage of disease at presentation, and stage of presentation drives mortality more than in almost any other solid tumor cancer. So to illustrate this point a little bit, this paper in JCO back in 2014 by Walker talked a little bit about the different cancers and who gets a treatment. It looks a little bit at treatments and who's able to obtain treatment in the Medicare population. And it's stratifying by Medicaid coverage and uninsured. And it looks first at who gets treatment, and treatment would be localized therapy, either surgery or radiation, and then it's going to look at survival. So the first slide here shows you lung cancer, right, and mixed of all the other cancers there, and you can see they're comparing, the reference would be private insurance, and then there's Medicaid and uninsured. So you can see the Medicaid here in yellow and uninsured in blue. And for lung cancer, you can see, well, maybe it's good to be on state Medicaid. It seems to help a little bit, but it still doesn't get you to the baseline. And this is for people who are going to have treatment. This is getting them to localized treatment. This is not survival. What you do see here, though, what you do see here is that, unfortunately, when you look at survival, there's very little difference between Medicaid and uninsured patients for survival for lung cancer. that should be concerning to us. That should be really concerning to us, right? We're talking about comparing people who have private insurance to who ended up having Medicaid or uninsured, and it looks like there's very little difference. And it's very common in all the other cancers. I'm picking out lung cancer because that's what we're talking about today. But this is a major issue for us, right? One of the things that ACA has done that's very good is actually shifted some folks more to state Medicaid from the uninsured rolls. But the problem is if that doesn't help you get to the treatment that you need, this is a specific problem. And as we think about federally qualified health centers, as we think about our rural areas where people don't have access, not being able to get to treatment really will have disproportionate effects on that community. So a little bit, the last thing I want to talk about, at least as far as SES goes before we move forward, is this is some work that we did looking at quality of life value. So you look at quality of life at the time of diagnosis when you stratify specifically by people who have financial toxicity. So much of the financial toxicity research has talked about cancer makes you poor. We were saying what happens if you're poor when you get diagnosed with cancer. And what we found, and this specifically looking at lung cancer and colorectal cancer, what we found is that patients who were poor at the time of their diagnosis had much worse quality of life. And for the lung cancer patients, they experienced more symptoms, increased pain, and shortness of breath, even when you're controlling for all the variables that we like to control for. So it's important as we start to think about screening that we think about how these things affect the populations who are at highest risk, right? African Americans at highest risk for lung cancer, folks who are lower socioeconomic status, who are not college educated at highest risk, and yet those are the very people who have been not included in LST and are really hard to get to in real life. So I want to illustrate this by talking about some subgroup analyses, and we all hate subgroup analyses. I understand they're not great, and doing stratification by race on a group of patients who that it wasn't meant to do that is not going to be great, but it is hypothesis generating, and that's what we want to talk about. And the Tanner paper, I think, does a really good job about this, looking at racial differences in outcomes in an LST trial. And there's a lot of things about this paper that I think are not perfect because they didn't have the ability to go back and do a lot of things retrospectively. But what you find is that lung cancer screening, we knew that it decreased mortality for all groups, but even more so in African Americans. And that's knowing that Black patients were younger, they had more comorbid disease, they were less educated, but they seem to have a greater benefit. And looking at screening and other diseases, at the end in the discussion of this paper, they really talked about the question of utilization of lung cancer screening in vulnerable patient populations. Every time we roll out a screening or a new technology, is always harder to have that happen for vulnerable patient populations. In this case, if you think about African Americans, people who don't speak English, immigrants, especially East Asian immigrants who might have a higher smoking, incidence of smoking. I think, the problem is we're talking about this, we're talking about narrowing it, but we haven't really increased the access to people who probably need it the most. And I think it's a really important part of the discussion. And Elise will talk about her own work later on, but let's talk a little bit about risk prevention and smoking cessation, because I do think even though smoking cessation and lung cancer screening are not necessarily synergistic, they are integral to this because there are teachable moments that we can, as clinicians, we can use these moments to get in and talk to our patients and help them stop smoking. And if we do not tailor our smoking cessation messages specifically for our communities, I think we risk an opportunity. And so if you talk about lung cancer screening and you use this as an opportunity to increase your screening, opportunities to screen, and also to beef up our lung cancer screening programs, let's to be honest, and as we've talked about before, many people refer to a Quit Works program or a Quit Line, which is better than nothing, and it's great to write prescriptions, but we know from the data that that's really not great for a lot of people. And again, what do you do if people don't speak English? What do you do if people are working a job where they can't take days off from work? We really have to think about this differently. So, and again, I'll at least talk about her study later on, but certainly the idea that there are different risk perceptions between current and former smokers, and in the former smokers, there did seem to be some racial differences, with whites having a greater risk perception or understanding of their risks than blacks, and discussing, how this would affect smoking cessation. And then we did two studies, ironically, the HINT study, which is the quantitative study, was a survey, which I'll talk about first. That work was done after the qualitative work, but but it took so much longer to publish that it came out later. So we'll talk about it in the way that they were published. We'll talk about the HINT survey first. So the HINT survey, and for some of you might be familiar with this, is a health information trend survey, public use database. It's been really, really useful. Now in the internet age, I think it's been harder to utilize because this is a phone survey. And the idea is, who answers the phone today? I don't know about you guys, but many people don't answer their landlines anymore. But at the time, it was very, very useful. And the question that we had back then is, do white patients and black patients view lung cancer differently? And the reason I was asking that question is because in some of our original work looking at disparities in lung cancer, where we showed that we followed up on Peter Bach's work, where he showed that African Americans were not getting lung cancer surgery for their lung cancer, and then we updated that by looking at who's getting invasive staging, and we found the same thing that he did. The surgeons would come to me and say, well, the problem is that the patients are saying no. And there's the patients, the idea that there are these myths out there that allow patients to say no because they're afraid that the air causes cancer to spread and all these other things. And so I wanted to say, well, perhaps African Americans and whites viewed lung cancer differently, and there are different ideas. What we found is that overall, people they didn't know a lot about lung cancer, but that was equal between genders and race. There were some differences. African American patients expected more symptoms, and now this was published in 2010, so really pre this idea that screening was going to be around. They were reluctant to seek care for fear of the disease, and they were confused about preventative recommendations, which if we were just talking about this study by itself, I spent a lot of time on that. There aren't too many preventative recommendations for lung cancer, and to be confused about that should be concerning to us all, right? There's really one big one. So what we did with the qualitative work, and that's, we wanted to explore some of these themes in lung cancer, fear and fatalism and mistrust, because this comes up over and over again, that these are the issues that are really interfering with people accessing care. And was there a lack of knowledge in lung cancer risks and outcomes? And, I will save you from all the things that we did in this, but I want to talk a little bit about, what we found. Patients wanted more help with their smoking, more compassion from their docs, and they wanted to know about seeing images of their lungs. I can't tell you, I was in each of these focus groups and it would always come up. And this is, again, before any of the NLST data came up, so we're just talking about chest x-rays. And what would happen is people would say, well, yeah, my doctor talked to me about quitting and they wrote me a prescription, but is there any way they can check on this? And there was no data for this, so we'd always say, well, there's no data for that. But it came up over and over and over again. And that's why we published one of the quotes. I think it's the only thing they can do to stop a serious smoker. You know what I mean? Say, listen, we're going to do this. We're going to take a picture of your lungs. Each year you keep smoking. And I thought it was very interesting because later on, suddenly there was data on screening. And at the time, we just thought this was very odd. Why would they say that? And I'm using this not to say that a qualitative study should inform our policy, but this idea that, the patients themselves, maybe they don't want this and they don't want to do this. I think it depends on the patient. I think the idea, as we talked about, this is an individual decision that should be discussed with patients, and they can review their risks and they can go over this in the manner that's suggested. And I just think it's important not to forget that. So just an idea, and just kind of reflect a little bit on this, and then I'll show you some data because I still have a few minutes left. So we talked a little bit about racial disparities in lung cancer and the incidence and mortality differences, the stage of presentation differences. We talked about how NLST showed some increased benefit of screening in African Americans, but what about other ethnic groups? Of course, we don't have the data for that for people who self-identify as Latino, and as we know, that's a very heterogeneous group. So you're talking about people who self-identify as Mexican or Cuban or Puerto Rican, and I think that this is information that we need. We need information on nativity, which we don't have. Where were you born? That sort of thing is really, really important. And we know that in health services research, we have overemphasized racial differences, and we really haven't added in these other granular aspects that can help us with socioeconomic status. And, this idea of targeted education outreach is needed in communities. We have one approach for smoking cessation. If you look at the tools that are out there, other than occasionally translating into Spanish, there are very few of these programs that really are targeted to specific vulnerable communities. And I think that that's extremely important. That's something that we have to do. And I think the reason I'm talking about it that way is if you're going to have a screening program, then you need to have an equally strong smoking cessation program. And if you're going to get to the community, you need to target the community and talk to them. We can't just set up a program and then expect people to come. And then that's what I did. So we set up a program. So just want to show you some of our challenges. We were interested in this idea. We have our cancer care equity program is really this pilot. We're embedded in a federally qualified health center where 70% of the patients are African American, 50% of them speak Spanish, so it's a high Dominican population, and most of them are below the poverty level. And we do a lot of things there. Lung cancer screening was not the first thing we did. We did many, many things. But as the data became as the data came out, as the NLST paper was published, and then we were in that zone where there was no recommendations, but we had people asking us about this, we had a grant, a philanthropic grant, where we implemented the NLST criteria, and we wanted to, go ahead and try to screen patients who fell into that criteria. And we're not going to go. This is our model. It's been published elsewhere, but basically, it's a nurse navigator model, where we have oncologists rotating in. Patients will start, it's in the primary health care center. They're referred to us for lots of different reasons about oncology, where we're trying to help them. And then as we developed this screening program, primary care docs could refer to us patients that they wanted to perhaps have us have that medical decision-making conversation with them. And we've had a lot of problems. So I will share with you, this is our process map. And the issue is that, just what you've heard earlier, primary care docs are confused about the guidelines. Primary care docs are also, it's very difficult. The EMRs have not been helping them as much. Many people get asked, do they smoke? But they don't, the pack year history isn't in there. So then when we try to figure out what, who should be screened, it is very difficult for them. So we manually do this with our nurse navigator, but if we weren't there, it would be very difficult for them. Also, what we found is over the year and a half that we've done this, there are about 500 people who by age criteria and smoking status could be potential people would fall into our screening category, but only 10% get referred to us because they don't know their pack year history. And we really work with the primary care doc specifically to try to address this. And so, the challenges, as I mentioned, internal physicians, the internal medicine physicians were the key there. We need a reliable tobacco history. We need great tobacco cessation programs. There are the confusions about the guidelines. And I think this idea of centralized versus decentralized process. So there are many hospitals that when they do this screening, they actually control this and have the primary care docs refer to them and they take over. Well, that has some pitfalls, right? Then, I think it's really not necessarily, you heard some of the problems with that. Perhaps the specialist wouldn't really have equipoise in this. The problem with decentralizing it is you do lose a lot of people. Sometimes the primary care docs will refer and they're busy. You heard this already. And so what happens with the follow-up? So that's very difficult. So we really need to figure out how we're going to help in these specific areas. And as I mentioned, tobacco cessation has to be an equal partner in screening and not an afterthought. And I think that's it. Thank you.